Rheumatology is actually a very fun topic, but a lot of doctors are actually scared of rheumatology and the approach to a rheumatic disease patient. So what I want to do is cover topics to make you more comfortable in the evaluation of a pediatric patient who may have a rheumatic disease. One of the things when you approach any kind of case, whether it's a patient who has earaches or a patient with joint complaints, just remember, these patients are more likely to present in one of four ways. They can present with a common diagnosis, with common symptoms, as well as common signs. So if a patient has an earache, fever, runny nose, and they're tugging on the ear, chances are they probably have otitis media. So it looks like a duck, quacks like a duck, chances are it's a duck, right? Now, there are some patients who may present with common symptoms of an uncommon disease. An example of this is that a patient who has dermatomyositis, and the patient presents with Gaucher's, papules, as well as a heliotropic rash. It's uncommon. So just because you hear hoofbeats, you don't necessarily think about horses, but sometimes there are zebras. And then there are certain cases where they have a common diagnosis with uncommon signs and symptoms. So an example of this is a patient who presents with arthritis, purpuric rash in the dependent portion of their legs, and as well as abdominal pain. So rash, arthritis, abdominal pain, you think about HSP or henochronal line purpura or IgA vasculitis. Well, the patient may present with ilio-ilio intussusception, and I'll go into that with my slide. So, for example, it's like, you have Elwood, the world's ugliest dogs. Dogs are very common, right? But it's not very common for dogs to be ugly. So again, HSP is common, but it's not common for patients with HSP to have ilio-ilio intussusception. Then there are those cases where they have an uncommon diagnosis presenting with uncommon symptoms. An example of this would be a patient with systemic juvenile idiopathic arthritis who present with macrophage activation syndrome. Scary stuff, rare. So a real-world example is the ii. This is the world's largest nocturnal primate in Madagascar. So it's very rare that you would encounter this primate, and very rare that primates actually look like this. So what I'm going to do in this lecture is to cover common rheumatologic diseases. Remember, it's about patterns. It's not about laboratory values, so I want you to be familiar and to be able to recognize patterns. So the topics that I will be covering include juvenile idiopathic arthritis, systemic lupus, vasculitis, Sjogren's disease, mixed connective tissue disease, juvenile dermatomyositis, systemic sclerosis, and localized scleroderma, such as morphia, the pain syndromes, and then finally autoinflammatory diseases, which are different from autoimmune diseases. Remember, pattern recognition, no one lab will make the diagnosis. So if you start to see something, and then you'll find and figure out the diagnosis. So how do you approach a child with this musculoskeletal complaint? You have to ask yourself the following questions. Does this represent a systemic inflammatory rheumatic syndrome? Do their symptoms actually represent something else that mimics a rheumatic symptom, such as an endocrinopathy, infection, or malignancy? What about drug side effects or toxicity? And perhaps, is this a generalized soft tissue pain syndrome? Perhaps fibromyalgia or pain amplification syndrome? Was there trauma? Maybe they have a fracture. You have to know what the red flags are. And red flags are what symptoms and diseases that can carry significant morbidity and mortality that you have to make the diagnosis immediately. This includes fractures, infection, and impending organ damage. So just remember, common conditions occur commonly, and most skeletal muscular conditions are self-limiting. But sometimes you might have to reevaluate the patient over a period of several different times in order to make the diagnosis. So just to give you the basics, joint pain, if it's purely just pain, it's called arthralgia. And if there's inflammation, it's arthritis. Now the boards, when they give you a board question, will not say, this child has arthritis. They're going to say, this child has rubor or erythema, swelling, heat, and pain in the left ankle. So the cardinal signs of inflammation is rubor, tumor, calor, and dolor, what you learn in medical school, right? So, but not only that, in patients with inflammatory arthritis, they have prolonged morning stiffness that improves with activity. Usually by the end of the day, they feel so much better and they don't hurt as much. So you want to categorize arthropathies in order to recognize patterns. Is this inflammatory or non-inflammatory? How many joints are involved? 1 joint, 3 joints, multiple joints, like over 12? Did the condition occur acutely, which makes you think about infection or fractures, or did it occur chronically over a period 6 weeks or more? Are the signs and symptoms of arthritis symmetrical or asymmetrical? Because certain patterns, such as oligoarthritis, tends to be asymmetrical, whereas lupus tends to be symmetrical. There are certain specific joint patterns, whether or not it's in the axial spine, you think about enthesitis-related arthritis, or in the peripheral joints, such as polyarticular juvenile idiopathic arthritis. Are the DIP joints involved or the MCPs? And then lastly, are there other organ systems that are involved? So just to remind you what the DIP joints are, DIP stands for distal interphalangeal joints. This is your distal knuckles. The PIP stands for proximal interphalangeal joint. The IP joint, because it's in the thumb, there's neither distal or proximal, so it's just called the IP joint. The MCPs are the metacarpal phalangeal joints, and they are at the base of the fingers. CMC joints typically are at the base of the thumb, the CMC1. This is where adults get osteoarthritis. So I'm giving you patterns, and this is just a very simple question. A 15-year-old girl presents with 3 months of swelling and pain in bilateral PIP joints and MCP joints and wrists. She notes it takes at least an hour for her to get ready for school because her hands are so stiff. Once she moves, she's fine. Afternoons are the best time of the day for her. So the question is, does this patient have an inflammatory polyarticular arthritis, an inflammatory asymmetric oligoarthritis, an inflammatory monoarthritis, or a non-inflammatory polyarticular arthralgia, non-inflammatory pain syndrome? So if you enter in your response, and that is correct. This patient has an inflammatory polyarticular arthritis and it's symmetrical. It affects her PIP joints, MCP joints. She has morning stiffness that improves with activity. These other answers are incorrect because she definitely has an inflammatory, not a non-inflammatory, symmetrical because both hands are involved, multiple joints. So management of the disease depends on whether or not the joint is inflammatory or non-inflammatory. I'll be discussing non-inflammatory joint pain on Friday in the sports medicine orthopedic section. But these are some examples of mechanical joint pain. This is Schuermann's kyphosis. This is where there's anterior wedging of at least 3 thoracic vertebrae. And typically these patients have pain that gets worse with activity. And then there's patients with spondylolisthesis where there's a slide of the vertebral spine, and that also causes pain. So let's get started here. Juvenile idiopathic arthritis. This is probably the most common childhood rheumatic disease that you're going to encounter. Prevalence is about 1 in 1,000 children. And just note, 300,000 children in the United States have JIA, but only 350 board-certified pediatric rheumatologists can see them. 8 states do not have a board-certified pediatric rheumatologist. So the onus is on you to be able to diagnose these patients and perhaps start them on treatment by the time that they get to a pediatric rheumatologist. The definition of JIA includes that the patient is under 16 years of age. They have persistent synovitis, and persistent means more than 6 weeks. And this involves 1 or more joints, and all other diagnoses have been excluded, such as malignancy and infection. The International League of Association of Rheumatologists, ILAR, classification of JIA, categorized JIA into 7 subtypes. You may be familiar with this already. The first one is systemic JIA, and as the name implies, this includes the whole body system. Patients may present with fever, weight loss, lymphadenopathy. Then you have oligoarthritis. This is where patients can present with 4 or fewer joints. And if the joints are still involved after a period of 6 months, it's called persistent oligoarthritis. If more joints are involved after 6 months, so that there's 5 or more joints involved, it's called extended arthritis. Another category of JIA includes the polyarthritis. They are further categorized as rheumatoid factor positive or rheumatoid factor negative. This is where there's at least 5 joints involved. It's very similar to adult rheumatoid arthritis. Psoriatic arthritis, enthesitis-related arthritis, and undifferentiated arthritis are the other categories of JIA as defined by EILAR. So exam clues, as I noted before, inflammation. Typically, patients will present with morning stiffness. They may not want to walk. They may not want to play in the morning, but by the afternoon, they actually feel a lot better, these children. Sometimes these children will lose milestones. They may have enuresis. They may refuse to feed or bathe themselves because of the inflamed joint. And sometimes they will not even complain. It's what mother notices. If untreated, leg length discrepancy can occur in patients with active inflammation that's been chronic. So the first category, systemic onset JIA, we like to term this as SOJA. And this is where it requires fever. It's a quotidian or diquotidian fever pattern. So the fever spikes are very predictable, and these are high fever spikes. These aren't your 99-degree Fahrenheit fever spikes. These are 103, 102 degrees Fahrenheit. And typically, you can set your clock by the fever spikes. They're in the late afternoon to early evenings. Whenever the patient has the fever, they have associated joint pains as well as muscle aches. When the fever's gone, the child's perfectly fine. They'll go run and play. SOJA accounts for about 10 to 20% of all JIA cases. Boys are affected as often as girls. And the peak age here is between 2 and 10 years of age. Now, prognosis is poor if a child presents before the age of 4 or if the disease persists for more than 1 year. Currently, I have a patient who's 25 who started having SOJA at the age of 7, and she has stunted growth. So, things to look for. If you remember, with systemic onset JIA, these patients can present with a salmon color rash, and the reason why they call it salmon color is because it does look like salmon. The rash is very discrete in its borders. They could be macular or papular, and typically they occur in the trunk, the thighs, and the axilla. And if you were to scratch exposed skin that's not affected by the rash, you can actually bring out Koebner's phenomenon and bring out the rash. The majority of patients with systemic onset JIA will have a polyarticular arthritis. So usually they'll have 6, 8, 12 joints involved, but about a quarter of them will have oligoarthritis. There are associated findings with SOJA as well. Patients can present with serositis, so they can have pericarditis, myocarditis, pleuritis, or serositis, abdominal pain. These patients present with swollen lymph nodes. They're very large around the cervical, axillary, or groin lymph nodes. They can also have hepatosplenomegaly, abdominal pain, weight loss, fatigue. Now, this is really unique to patients who have systemic onset JIA. They have muscle pain and muscle aches, but their CK is normal. However, their aldolase is elevated. It's very unique with this disease. CK being normal, aldolase being elevated. Uveitis is rare in this condition. When you look at these patients' labs, it's a huge milieu of active inflammation. They have high white counts, sometimes up to 40,000 per microliter. Their platelets are also elevated. This is an acute phase reaction, sometimes over 1 million platelets. They have high sed rate, high CRP, high ferritin. Sometimes the ferritin can go into the thousands. They'll have an anemia of chronic disease, low albumin because of the chronic inflammation. The rheumatoid factor will be negative, and usually the ANA will also be negative. Now, there's one thing that you have to recognize, and this may be on your boards: macrophage activation syndrome. And the reason why you have to be able to recognize this is because mortality is very high. It's extremely rare. This is one of your eyes from Madagascar, but you might encounter this, and you may save a child's life. So in order to make sure that you remember this, I put a case together. IJ is a 9-year-old male with a recent diagnosis of systemic onset JIA. He develops persistent high fever, jaundice, and multiple bruising on his arms and legs after a viral infection. His temperature is 102 degrees. On exam, he looks bad. He's ill. There's bleeding around his gums. Lymphadenopathy and hepatosplenomegaly were also present. His lab shows a white count of 2.6. Ding, 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 look at this. Normally, patients with SOJA will have a high white count, right? But his white count's low. His hemoglobin is 7.2, and his platelets 85,000. Another ding here. Usually platelets are high, not low. AST is 710, ALT is 886. His SED rate is 20. This is also another ding, ding, ding. Pay attention to white counts, SED rates, look at the platelets. Ferritin is elevated, as would be expected in patients with juvenile onset stills or systemic onset JIA. So if you did a bone marrow biopsy of these patients with macrophage activation syndrome, you'll see activated macrophages, just like the name implies. This one's engulfing a red cell, but they can also engulf other cell types. The biopsy is indistinguishable from hemophagocytic lymphohistiocytosis, HLH. Again, high mortality if not recognized. These patients can have neurologic dysfunction. They should be in the ICU. Serum transaminases could be very high. These patients can have a coagulopathy, and their fibrinogen levels could be low. And that's one of the things why the SED rate is low or normal, is because for the SED rate to be elevated, you need a lot of fibrinogen. These patients can have cytopenias. Typically, the platelets will drop precipitously. And then the bone marrow, again, hemophagocytosis of other cell kinds. Typically, MAS is triggered by a viral infection, but active JIA itself can do this. Medications that have been linked to macrophage activation syndrome include sulfa drugs as well as nonsteroidal anti-inflammatory NSAIDs. You want to treat this condition aggressively. So you want to be using high-dose steroids, IVIG, biologics. We also use cyclosporin. We really avoid slow-acting drugs such as methotrexate, sulfasalazine. All right, let's get back to the topic of systemic onset JIA. Question for you. 3-year-old boy presents with 4 weeks of fever, 102 degrees Fahrenheit, and a faint rash on his chest that occurs at 4 p.m. every day. When he has fever, his joints are also swollen to the point he wants to be carried everywhere. Once his fever breaks, he returns to normal activity. Exam noted an ill-appearing boy with a temperature of 102.4, large cervical adenopathy, and synovitis in his hands, wrists, elbows, shoulders, and knees. He has mild wrist contractures. Which of the following is true? A, liver involvement is rare. B, treat with empiric antibiotics until blood and urine cultures are resulted. C, uveitis is common. D, labs will show a low ferritin but high white blood cell count. And E, he's at risk for myocarditis and serositis. Your answer, please. The answer is Z, so I'm glad that you're paying attention. Liver involvement is common with systemic onset JIA. You don't necessarily have to treat with empiric antibiotics because he's not infected even though he has high fever. Uveitis is not common in systemic onset JIA. It's common in oligoarthritis JIA. Labs will show a high ferritin as well as a high white blood cell count. So E is the only one that's correct in this circumstance. All right. Oligoarthritis, also known as polyarticular JIA. This accounts for about 1/3 of all JIA cases. Typically, the child will present at age 1 through 5 years old. The average onset is 1 to 3 years old. And this is your little blonde hair, blue-eyed girl who walks with a limp, swollen right knee, ANA positive with uveitis. So that's your pattern right there. Female to male ratio is 3 to 1. And those with uveitis are more likely to be females. Typically, there's 4 or fewer joints involved in the first 6 months of disease. And 1/4 of these patients will not complain of pain. They'll just limp. Or mom will notice that the knee looks a lot more swollen. The joints that are typically involved are the knees, the ankles, elbows, and wrists. Although the TMJ joints, the temporomandibular joint, can be affected, and sometimes you may need to have an MRI if a child cannot open their mouth, or an ultrasound in order to evaluate the TMJs more carefully. Now, if the patient has fever, rash, or nighttime pain, think about a totally different diagnosis as infection or something else. It's not going to be oligoarticular JIA. These kids look really healthy. They just have a swollen knee. On labs, about 70% of them may have a positive ANA. Hemoglobin and rheumatoid factor are typically normal, and the SED rate and CRP are normal. They don't have a lot of inflammation. Now, the one thing about oligoarticular JIA that I really want to emphasize is that these patients may have an asymptomatic uveitis. They won't complain about vision disturbance or eye pain or rub their eyes. So if you suspect and make the diagnosis of oligoarticular JIA, you need to send these children to a pediatric ophthalmologist for a slit lamp exam. The prevalence of asymptomatic uveitis is about 30% of all patients, and again, typically associated with a positive ANA. And in the core curriculum book for a pediatric room, it's going to tell you how often you do the slit lamp exam. If the patient is ANA positive and the child is under 6 years old, you would do a slit lamp exam every 3 months. If they're over 7, you do the slit lamp exam every 6 months instead of every 3 months. All right. Here's your question. 2-year-old female child presents with a swollen right knee. A few months ago, mom observed that the child would not play with her sisters in the morning, but would be running with them by lunchtime. Later, she noted that the child's right knee was swollen. She has difficulty climbing stairs. Mom thought that her daughter had fallen and injured it. Evaluation noted a swollen right knee with a large effusion. Lab shows normal CBC and SED rate, and her x-rays were unremarkable. Which of the following would best describe the child? This child likely has an ANA positive oligoarthritis JIA and is at risk for uveitis. Or she has an RF positive oligoarthritis JIA and is at risk for uveitis. C, she will develop polyarticular JIA. D, she is at risk for systemic onset JIA. Or E, she has juvenile psoriatic arthritis. That's correct. A is the correct answer. It's not very common to see rheumatoid factor positive in patients with oligoarthritis JIA. The other thing is that this patient, usually the prognosis is very good and usually will resolve with time, but very rarely it still can extend and become an extended oligoarthritis. And at that point, we will treat them with disease-modifying anti-rheumatic drugs. The patient is not at increased risk for systemic onset JIA. And you got to remember, any board question, if they don't say specifically that the patient has something, then don't assume they have something. So I didn't say that the patient had psoriasis, so don't say that the patient has psoriatic arthritis, okay? So don't, overguess yourself and overthink it. All right, polyarticular onset JIA. These patients look like adult rheumatoid arthritis. They will present with 5 or more joints in the first 6 months. This accounts for about 30 to 40% of JIA cases, and girls are more afflicted than boys in a 3-to-1 ratio. There's basically 2 peak age groups, the very young, 1 to 3 years old, and the pre-adolescent or adolescent. Usually, if they're young when they present, the rheumatoid factor is negative, but in adolescence, the rheumatoid factor could be positive or negative. Typically, the small joints of the hands are involved, but large joints as the knees and hips also can be affected. And if it affects the TMJs, micronathia can occur, and also patients can also develop cervical spine fusion with chronic disease that's untreated. In these patients, you have to be careful if they require surgery, let's say an appendectomy, you got to make sure that they get flexion and extension views of their cervical spine to make sure that they don't have erosions in the C1, C2 vertebra that can cause atlantoaxial instability. The presenting symptoms for polyarticular onset JIA is typically fatigue as well as stiffness. Fever, weight loss, and rheumatoid nodules can also occur. So for patients who are rheumatoid factor positive, this is a poor prognostic sign. They tend to have a higher rate of deformities as well as erosions, radiographic erosions. The CCP antibody is also another antibody that we check. It stands for cyclic citrullinated peptide. If they have both rheumatoid factor positive and CCP positive, they have pretty aggressive disease and prognosis is poorer. About 30% will have a positive ANA. And if they are positive ANA, go ahead and send them to pediatric ophthalmology for a slit lamp exam. While uveitis is not as common compared to oligoarticular arthritis, JIA. So in patients with polyarticular onset, if the child's under 7 years of age, you still do 3 to 4 months slit lamp exams, particularly if they're ANA positive. Let's look at this question. 15-year-old girl. So this is the same girl I presented with the first question, right? 15-year-old girl presents with fatigue and 3 months of swelling and pain in bilateral proximal interphalangeal joints, PIP joints, and MCP joints, and bilateral wrists. She wakes up much earlier than her friends in order to get ready for school because her hands are so stiff. Her hands are shown here. And labs showed ANA being 1 to 80. Rheumatoid factor is 26, that's elevated. CCP is 150, that's also elevated. And the SED rate is 40. Which of the following is true? A, uveitis is common in this form of arthritis. B, patients with positive RF and CCP tend to have worse prognoses. C, this patient is likely to go into remission without long-term medication. D, because of the positive ANA, this patient has lupus and JIA. Or E, we see quotidian fevers in this kind of JIA. Your answer, please. Perfect. Uveitis is not that common. It can occur typically in ANA positive. B is the correct answer here. These patients usually will require lifelong, or at least for many, many years, of disease-modifying anti-rheumatic drugs. And because of the positive ANA, the patient does not have lupus. Lupus requires a set of criteria to make the diagnosis. And quotidian fever is not a common finding of this. It's a common finding of systemic onset JIA. So let's look at juvenile psoriatic arthritis. So the definition of psoriatic arthritis is that the patient has arthritis and psoriasis. But if they don't have psoriasis, arthritis with 2 of the following will also suffice: dactylitis, nail findings such as pitting, or a first-degree relative with psoriasis. This is an example of plaque psoriasis. Usually they have very discrete borders, it's thickened, hypertrophy. When you scratch the surface, there's a scaliness to it. Psoriasis in the nails, you can see pitting here, as well as onycholysis where the nail bed lifts up. And this is an example of dactylitis right here, where it looks like sausage digits. Now, the arthritis can precede psoriasis by many years, and typically it's found in patients who have nail pitting. DIP joints can be involved. There's actually several different subtypes of psoriatic arthritis. There's the DIP subtypes, where it affects the DIP, distal interphalangeal joints. There's those that look like they have rheumatoid arthritis, so symmetrical rheumatoid subtype. There's the subtype of psoriatic arthritis where it affects the spine only. That's the spondylitis subtype. And then there's the oligo subtypes where it just affects 1 or 2 joints, like the knee or the ankle. So psoriatic arthritis can mimic the other kinds of JIA. Uveitis is common in psoriatic arthritis, and these patients will be symptomatic. They'll have photophobia, they'll have tearing, they'll have redness in their eyes. ANA positivity can occur in these patients, 30 to 50%. If the child is younger, psoriatic arthritis is more common in girls, but if the child is in their pubertal years, presentation is more common in boys. And this is just an example of synovitis here. Enthesitis-related arthritis, ERA. This is another category of the ILAR-JIA system. So the terms juvenile spondyloarthritis, juvenile ankylosing spondylitis, HLA-B27 associated arthropathies, and C syndrome, syndrome of seronegativity, enthesopathy, and arthropathy, these are out. These have all been combined in the whole category called enthesitis-related arthritis. And in fact, in the adult world, adult rheumatology, we actually lump psoriatic arthritis as part of the enthesitis-related arthritis, as well as inflammatory bowel disease arthritis. So what exactly is enthesitis? Enthesis is basically where there's ligament, tendons that attach to bone. So the Achilles tendon back there, where it attaches to the heel, and the patient can have heel pain, that's an enthesis. Enthesitis is there. Right by the patella, where the patella tendon attaches to the tibia, that's also an enthesis. Also, the iliac crest has an enthesis, as well as along the spine. So just wherever there's ligament that attaches to bone, that's an enthesis. Now, what you may not know is that the nail bed is also an enthesis. So where the fingernail attaches deep into the bone, that's an enthesis. And that's why some patients will have lifting of their nail bed, of their fingernails, and we call that onycholysis. ERA is half as common as all the other JIAs combined, systemic, oligo, and polyarticular JIAs. About 20 out of 100,000 children are affected, and the findings that are associated with ERA is HLA-B27 antigen. It's found in 50 to 90% of patients. Typically, these are older children. Males are more afflicted than females. There is a familial association. So if mom or dad has ankylosing spondylitis or inflammatory bowel disease related arthritis, then it's possible that the child will also inherit the HLA-B27 gene and have ERA. If HLA-B27 is present, chances are the spine can be involved. The arthritis can be peripheral or it can be axial. And if they have lower limb involvement, it's typically asymmetrical in nature. So how do you diagnose ERA? The definition is if the patient has arthritis and enthesitis. But if they don't have one of these two, if they don't have both, then one of these two plus two of the following will suffice. SI joint pain, sacroiliac joint pain, or inflammatory spinal pain. So these children will wake up in the middle of the night complaining about their back hurt, the buttock hurt, they're really stiff, they have to get up and stretch and move, or if they can't sit still in the classroom because sitting still hurts their butt a lot. So that's the kind of presentation you'll see in these children. The presence of HLA-B27, first-degree relative with HLA-B27 disease, acute symptomatic uveitis. Remember, this uveitis is painful, just like psoriatic arthritis. And the onset of arthritis in a boy greater than 6 years old. So arthritis or enthesitis plus two of the following. So this is just an emphasis of what I've already just gone over. Some of the patients can present with severe heel pain at the heel, the feet, the knees. There's really no systemic symptoms. These patients are not sick, not like systemic onset JIA. The patients who have uveitis, also known as iritis, can present with a painful red eye, and this occurs in 5 to 10%. Now, the SED rate is very unreliable because it could be normal in half of the cases. And so a patient may be in complete remission and their SED rate could be really high, or the patient can have really active disease and their SED rate will be normal. So here, the SED rate is unreliable. Now, when a patient presents with enthesitis and arthritis, or other kinds of JIA, you got to keep in mind the differential diagnosis, making sure that this isn't an infection, this isn't because of another rheumatic condition like lupus, making sure that it's not because of trauma or from cancer. How do you treat these patients? Typically, NSAIDs are first line. We do use certain disease-modifying anti-rheumatic drugs. We call those DMARDs. And when there's moderate to severe disease, we really like to pull out the big gun and try to induce remission sooner than later. If one or two joints are involved, like in the oligoarthritis patients, I usually do a joint injection. But the typical disease-modifying anti-rheumatic drugs that you'll see in clinical practice will be methotrexate. And methotrexate sounds really scary to parents because it's a chemotherapy drug. They read about it, they're like, oh my gosh, my child will lose all their hair, they'll have bone marrow suppression, infection. So they're thinking about worst case scenario. But the dose of methotrexate rheumatologists use is a fraction of what the oncologists use. We just want to calm inflammation down. We don't want to kill any cancer cells. And so, and children metabolize methotrexate very well, and they do very well with it. The biggest side effect of methotrexate is fatigue. There is kind of like a helpful hint in patients who are on methotrexate and who have fatigue. We give them dextromethorphan, so Robitussin DM perks them up. It's very interesting. But other side effects of methotrexate you should be aware about is that some patients can have allergic reactions to it or an interstitial pneumonitis. If it's a teenager, you have to caution her about getting pregnant because it's a Category X, FDA Category X for pregnancy. Sulfasalazine, hydroxychloroquine are also used. With sulfasalazine, there's a lot of pills. And I always tell my patients that your urine's going to turn bright yellow and it smells like rotten eggs. But it is very safe. There's not a whole risk of infection, but the children really don't like to swallow these pills, which are about the size of a calcium pill. It's pretty big. Hydroxychloroquine, you worry about retinopathy. And so this is a drug that we use, particularly, let's say it's a teenager who's pregnant, so it's safe in pregnancy as well. Cyclosporin for patients with systemic JIA or macrophage activation syndrome. And then for patients with aggressive disease, we pull out our biologics. One of the first biologics approved was actually a TNF inhibitor, etanercept, soluble TNF receptor. It's not effective for inflammatory bowel disease, though. Etanercept isn't. Adalimumab and infliximab are. These are the monoclonal TNF inhibitors. CTLA-4 Ig, this is abatacept, binds to T cells, and it's also been approved for children. And then tocilizumab, it's an anti-IL-6 inhibitor. It also has been used for patients with juvenile idiopathic arthritis. For patients with systemic onset JIA, we usually go forward with IL-1 inhibitors, colchicine, or IL-6 inhibitors. I'm not sure whether or not the boards are going to be detailed about whether or not you have to know these biologics. I assume that they just want you to be familiar with it without having to go through the details of toxicity. So for patients with psoriatic arthritis and ERA, we also use NSAIDs and disease-modifying drugs. But if they have enthesitis, the oral DMARDs will not work. If they have enthesitis and spinal involvement, we have to use biologics, infliximab or adalimumab. The emerging therapies that have been approved for adults is apremilast. Works very well to get rid of psoriasis, and you really don't have to do much monitoring in terms of labs, but it's not approved for children yet. Ustekinumab is also another drug that has been approved for adults, and I think they're studying this for children now, as well as secukinumab, which is an IL-17 inhibitor. At all possible, we like to avoid corticosteroids because steroids have a lot of side effects. They can stunt the child's growth, they can cause infection, adrenal insufficiency, diabetes, hypertension, cataracts, glaucoma. So I told you about my patient with systemic onset JIA, how she stunted her growth because of all the steroids that she had to receive. She's age 25. Well, she had pretty much every one of these side effects. Cataracts, glaucoma, stunted growth, diabetes, osteoporosis, and she's fractured multiple times. She's currently in remission with adalimumab. Inflammatory bowel disease, associated arthritis, about 25% of those with Crohn's or ulcerative colitis will have arthritis. And if peripheral joints are involved, then it mirrors gut activity. So if you treat the gut, the joint pain and swelling typically improves. Now, if they have spinal involvement, then it's totally disparate with gut activity. So it doesn't matter if the gut's well controlled, the spinal disease has a mind of its own. Typically, with spinal disease, boys are more afflicted than girls. I'd mentioned that these patients typically will have HLA-B27 positivity. We use TNF inhibitors in these patients. Now this, I believe you'll have to know on your boards. There is a box warning with the TNF inhibitors for children who are also on concomitant azathioprine. And this is typically in patients with Crohn's or ulcerative colitis. The combination of TNF inhibitors and azathioprine can cause hepatosplenic T-cell lymphoma. It's extremely rare. A few cases have been reported, but it's in the box warnings. So just be aware of that. It's been in the news last couple of years. Infectious arthritis. Now, infectious arthritis is caused by a pathogen, a bacteria or a virus in the joint. And it can be caused by direct inoculation or hematogenous spread. It's diagnosed by synovial fluid or else blood cultures. Risk factors are patients who are immunocompromised. They could be immunocompromised from HIV or AIDS, or what we use with our DMARDs and biologics. But diabetes, sickle cell anemia can also confer a risk for infectious arthritis. About 55% of cases, there's no organism that you can identify. But the most common pathogens are listed below. So Staph aureus, and we have to worry now about methicillin-resistant Staph aureus. Neisseria gonorrhea has been associated with sexually active teenagers. Viruses, such as parvo B19 and hepatitis B virus, has been associated with infectious arthritis. Salmonella is associated with sickle cell anemia. Kingella kingiae, children under the age of 4. Haemophilus influenza in patients who are not vaccinated. Reactive arthritis is different, though, compared to infectious arthritis. Reactive arthritis is the body's immune system going haywire after the pathogen is gone. Typically, it occurs anywhere from 1 to 4 weeks after an acute infection. Typically, it's GI or GU infection, but although I've seen cases where the patient could have a respiratory infection and then reactive arthritis develops later. The typical culprits, Yersinia, Giardia, Salmonella, Campylobacter, so these are the GI bacterias. But GU infections, chlamydia or mycoplasma, Lyme disease, strep infections have been implicated. Now there's a triad. You may remember this: arthritis, conjunctivitis, and urethritis. Can't see, can't pee, can't climb a tree, right? So that's reactive arthritis. Skin findings can be common. Keratoderma blennorrhagica. So these patients' feet can have really scaly, thickened, hyperkeratotic findings. They can also have oral genital ulcers. The arthritis is typically in a large joint. Usually it's asymmetrical. Fever can occur, so that's why you have to rule out active infection. Typically, reactive arthritis is self-limiting. It lasts only about 3 to 6 weeks, but in about probably 20% of cases, it can persist, and so we will use disease-modifying anti-rheumatic drugs. What's controversial is whether or not to give these patients antibiotics. So usually we will not give patients antibiotics because of the risk for antibiotic resistance. Now, because I talked about the role of antibiotics, there's a lot of controversy, and this is very, very interesting. So the Finnish published their national register. It's a case-controlled study of over 1,200 patients who have juvenile idiopathic arthritis, and they compared them to over 5,000 matched controls. And what they found were that patients who were on antibiotics, multiple courses, were more likely to develop JIA. And the strongest antibiotic association is with lincosamides, or clindamycin, as well as cephalosporin. Lincosamides, odds ratio here is 6.6 for the risk of developing JIA. Cephalosporin's 1.6 odds ratio. And the exposure when the child's under 2 years of age increases the risk by odds ratio of 1.4. So this is another reason why you want to use antibiotics sparingly. There was another study, the UK study. It's a nested case control study, 153 JIA patients with 1,500 matched controls. And they found that there is also a link in their database that JIA is associated with antibiotic use, odds ratio of 2.6. And the risk increases for each additional prescription, so that if a child receives 3 to 5 courses of antibiotics, the odds ratio is 3.8 for developing JIA. There's no association with antifungal therapy or antivirals, and no association at age of exposure in their study. So this begs the question, do patients who have JIA, are they at greater risk for infection? They're more susceptible to it? Is that why we have to use more antibiotics? Or is it because antibiotics alter the gut microbiota, and this is a contributor to the development of JIA? So I'm going to give you this audience response question. 10-year-old boy presents with exquisite pain in his heels and feet, as well as low back and pelvic pain. He noted that stiffness is worse during the night and lasts until lunchtime. The pain is in his SI joint areas, reproducible by palpation. His mom blames football. They blame football for everything, for his problem. There's no family history of arthritis on exam. He has no rash, no nail pitting or dactylitis. And laboratory test reveals a positive HLA-B27 with a normal SID rate. So which of the following does the patient have? A, oligoarticular JIA, B, enthesitis-related arthritis, C, sarcoidosis, D, psoriatic arthritis, or E, systemic onset JIA. Your answer, please. So you are correct. Enthesitis-related arthritis is what this patient have, who has buttock pain, enthesitis in his Achilles tendon, as well as other tendons. So the next topic is pediatric vasculitis. Vasculitis scares a lot of doctors. Vasculitis scares a lot of rheumatologists, too. And the reason why is because these diseases can actually carry a lot of morbidity as well as mortality. So I want to give you a flavor of vasculitis so that you'll feel a little bit more comfortable when you're managing a child with vasculitis. The way we categorize vasculitis is based on the size of the vessel, the blood vessel. If it affects the veins or arterioles and the capillaries, we think about leukocytoclastic meningitis. The small arteries, we think about HSP, or henoch-slow line purpura, and cryoglobulemic vasculitis. The small to medium-sized vessels, microscopic polyangiitis. The large to medium vessels, granulomatosis with polyangiitis, formerly known as Wegener, and EGPA, formerly known as Sjögren-Strauss. And then we have polyarteritis nodosa and Kawasaki's disease, which are large to medium-sized vessels. And then Takayasu's arteritis, which is rare in children, but can occur. And you may encounter a case. And these can affect large vessels, such as the aorta. So let's talk about the most common vasculitis you will likely encounter. So HSP, also called IgA vasculitis or anaphylactoid purpura, this can occur in about 1 in 5,000 cases, 5,000 patients. The classic triad. There's something about rheumatologists, we love triads. But the classic triad for HSP is purpura, dependent purpura, arthritis, and abdominal pain. The mean age is 4 years old. About 3/4 of the cases are in patients under the age of 7. Boys are more affected than girls in a 2-to-1 ratio. And there's a seasonal pattern. Typically, we see a lot more HSP cases in the winter and the springtime. And perhaps maybe there's an infection that could be contributing to the inflammatory response and immune derangement. About 50% of patients will have a preceding upper respiratory infection. And the hallmark of this disease is having elevated IgA levels. And in fact, if you biopsy the rash, you'll see the IgA. That's why they call this an IgA vasculitis. There are also other triggers that have been associated with HSP. Vaccinations with live vaccines, MMR, yellow fever has been associated with this. Group A, beta hemolytic strep, Legionella, mycoplasma, food additives, as well as insect bites. The skin lesion, it's very classic. Usually it's found in the lower extremity where there's a lot of pressure, so the buttocks, the lower extremity legs. In younger children, it can occur in their face and ears. And skin lesions are found in 100% of cases. And in fact, the diagnosis may be delayed because the physician is looking for the skin lesion, and eventually it will come, and aha, you have your diagnosis. The rash can last anywhere from 4 days to 4 weeks, and angioedema can precede the rash. Joint manifestations, that's the second most common presentation, and it will occur in about 50 to 80% of patients. Typically, it's the large joints, such as the knees, or medium-sized joints as the ankles. About 1/4 of patients will present with joint symptoms initially, and the arthritis is self-limiting. Really, we don't see chronic arthritis with this disease. There's no joint effusions. The x-rays are pretty normal. Sometimes you can see inflammation in the surrounding tendons. GI complaints are the third most common. These patients can have colicky abdominal pain with vomiting. Occult bleeding is common, and melena can occur in about 1/3 of patients. Patients can also have gallbladder hydrops, or thickened gallbladder on ultrasound. If they have abdominal pain, go ahead and get an ultrasound. You might see the gallbladder being thickened, but also ileo-ileo intussusception. This can present in about 2 to 14% of cases. Renal manifestations can occur in 10 to 50% of patients. They can have a microscopic hematuria. And there is a risk for permanent renal damage. It's rare, but it can occur. And it's usually in patients who have persistent purpura for more than a month, decreased factor 13, or persistent and severe GI symptoms. What's interesting is that over the last decade or so, they've been looking at factor 13 infusions in patients with HSP with severe symptoms. They found that it helped with the GI symptoms as well as with the joint pains, but it doesn't necessarily help with the renal manifestations. So that's something to consider if a patient has HSP and GI complaints. More rare is orchitis, but this may be the hallmark presentation of HSP. Patients can also have pulmonary hemorrhage. On laboratory, you'll find a high white count, high sed rate, high IgA level. But patients can have normal platelets and normal coagulation. Treatment is typically supportive. We don't like to use steroids because sometimes steroids can prolong the disease. We will use steroids for patients with organ-threatening illness, such as renal failure, as well as GI symptoms. Recurrences are common. About 40% of patients can have a recurrence in 6 weeks or up to 2 years from the first episode. So the next question for you. 5-year-old boy presents with abdominal pain and worsening rash. His mom noted he had an upper respiratory tract infection about a week prior to his current symptoms. On exam, you note petechiae and palpable purpura over the lower extremities extending to the buttocks. Incidentally, you noted our swollen right knee, and he says it started hurting this morning. Which of the following is not associated with this disease? Is it occult GI bleeding, chronic arthritis, ileo-ileo intussusception, hydrops of the gallbladder, or orchitis? Your answer, please. The correct answer is chronic arthritis. Everything else you can see with HSP, but we see a very self-limited arthritis. Kawasaki's disease. So Kawasaki's disease is the second most common childhood vasculitis. It affects medium-sized vessels, and you can see skin manifestations, mucosal membranes, and these patients can also have lymph nodes and cardiac involvement. Typically, children present under the age of 5, and it's usually preceded by a viral infection, just like HSP. There's 2 phases to this. Phase 1 is where there's fever. Typically, the fever can run high, up to 104 or more. The patient will be irritable. They'll have erythematous conjunctiva, oral mucosa, or the skin. So you'll see red eyes, red tongue, red skin. Peripheral edema in the hands and feet can occur. This is an example of peripheral edema. These patients also can have cervical lymphadenopathy, elevated LFTs, and joint symptoms. The joint symptoms can last about 1 to 2 weeks with treatment, but without treatment, it can last longer for about 4 weeks. The second phase of Kawasaki's disease is actually peeling of the skin. So you'll see the sloughing of the skin around the creases of the hands or even the toes. Some patients can also have diarrhea, vomiting as well. The American Heart Association published diagnostic criteria for Kawasaki's disease, and what you can use for it to help in the diagnosis of Kawasaki disease is fever of greater than 5 days, and 4 of the 5 main clinical feature. Extremity changes, like I had mentioned, edema of the palms, followed by membranous desquamation of the skin. Polymorphous exanthema, usually this is generalized, but it could be limited to the groin or lower extremities. Oropharyngeal changes, such as the strawberry tongue, but also diffuse mucosal injection of the oral pharynx can be seen. Bulbar conjunctivitis, typically this is non-exudative. They look like they got pink eye. It's painless. Vision is not affected. Lymphadenopathy, usually lymph nodes are pretty swollen, more than 1.5 centimeters. They can be bilateral, but usually they're unilateral. Kawasaki's disease is actually the leading cause of acquired heart disease in the United States. The most severe complication are coronary artery aneurysms, which can occur in 25% of patients without treatment. And some of these patients can also have myocardial infarctions, and this is a common cause of death. But there are other cardiac manifestations, such as arrhythmias, myocarditis, and pericarditis. In 2017, the American Heart Association published guidelines on Kawasaki's disease, and they recommend that you get an echo at the time of diagnosis, 1 to 2 weeks after treatment, and again 4 to 6 weeks after treatment. And so how do you treat these patients? And this is based on the 2017 AHA guidelines. You initiate immediately IVIG at 2 grams per kilograms over 12 hours, and high-dose aspirin, 80 to 100 milligrams per kilograms a day. You can repeat IVIG if needed. Now, some of you probably have read published data showing that low-dose aspirin may actually work as well. There's no higher rate of increased coronary artery aneurysms with using lower-dose aspirin, such as 50 milligrams per kilograms a day. In patients who are refractory to IVIG, they're still spiking fevers, go ahead and give them steroids, infliximab. We also use cyclosporin methotrexate. Antiplatelets and anticoagulations have also been used and are needed in patients who have thrombosis or coronary artery aneurysms. You can lower the dose once the fever is gone to about 3 to 5 milligrams per kilograms a day of aspirin. Recurrence is rare. It's very unusual. The rate of recurrence in Japan is about 3%. In the United States and North America, it's 1%. Now, one thing you have to know about Kawasaki's disease is that about 1% of patients can also develop macrophage activation syndrome, just like patients with SOJA, systemic onset JIA. So be on the lookout for that. So here's a question for you. 9-month-old girl presents with 1 week of fever and a red maculopapular rash on her torso. Mom notes that her daughter's mouth and hands are red and swollen. Exam notes a temperature of 103 degrees Fahrenheit, and eyes have bilateral redness of the conjunctiva. She has large cervical and axillary groin adenopathy. Her mouth shows a red tongue, but no ulceration or exudates on the tonsils. Hands and feet are edematous. Which of the following is true? A, this patient is at risk for chronic arthritis. B, the most common cause of death is renal failure. C, coronary artery aneurysms and myocardial infarctions are complications of this illness. D, avoid aspirin because it can cause Reye syndrome. Or E, the most common cause of this illness is strep pneumonia. Awesome, 100%. Perfect. So my next 3 vasculitis that I will be discussing, these vasculitides can cause pretty significant morbidity and mortality if unrecognized and untreated. The first one is granulomatosis with polyangiitis, previously known as Wegener's granulomatosis. It's rare in children, occurring about 0.1 in 100,000 children. These are necrotizing granulomatous vasculitides where the small vessel is affected. So if you notice in the name granulomatous vessels, so you'll see granulomas on biopsy. This is one of the few pulmonary renal syndromes that can affect the respiratory tract as well as the kidneys. About 91% of patients will have like an ear, nose, or throat manifestation. They can have nasal deformity, subglottic stenosis, or tracheal stenosis. So know what a flow volume curve looks like for children with tracheal stenosis. So it goes up, flattens out, and goes down and curves, okay? So the one thing about rheumatology is you gotta be good in all different specialties too, because these patients who have tracheal stenosis, you'll see this in flow volume curves. So, and some of them will have stridor. Constitutional symptoms can occur in 89% of patients where they'll have fever, weight loss, and fatigue. These patients can also present with epistasis, cough, sinusitis, as well as a saddle nose deformity. Skin and mucosa involvement occurs in 64%. These patients usually present with palpable purpura. And when you hear palpable purpura, buzzword for vasculitis. So it's non-blenching. Skeletal muscular systems can be involved in about 60% of patients. Typically, these are large joint involvements. Hematuria can occur in 50%. This is a true glomerulonephritis. And the eyes could also be involved. Patients can present with scleritis, conjunctivitis, dacryoadenitis, as well as proptosis. Now, the one thing that has been associated with GPA is C-ANCA. This is the cytoplasmic anti-neutrophilic cytoplasmic antigen. C-ANCA specifically targets PR3. So when you see C-ANCA positivity with PR3, think about GPA. You will find this antibody in about 67% of patients who have GPA. But the gold standard is actually doing a biopsy of the affected organ, if it's the kidneys or the lungs. Steroids are used for treatment, high-dose steroids, but we can't really keep these patients on steroids for a long time. So more recently, rituximab, it's a B-cell inhibitor. It depletes B cells, have been FDA approved for the management of GPA. Formerly, we've also used cyclophosphamide for immediate life-threatening conditions. The brand name for it is Cytoxan because it's toxic. We want to stay away from cyclophosphamide as much as we can because children exposed to cyclophosphamide can have infertility later on in life. If we have to give it to a boy, we usually bank his sperm. For girls, we'll go ahead and give Lupron to arrest ovulation. And secondary malignancies can also occur with cyclophosphamide. Methotrexate is used to maintain remission, as well as azathioprine. Recently, there was a study published using rituximab to maintain remission. It's a pretty safe biologic. In patients who have GPA, always use pneumocystis jirovecii pneumonia prophylaxis. These patients, because their lungs are affected, have higher risk for pneumocystis pneumonia. Bactrim, or trimethoprim sulfamethoxazole, has been shown to help with PJP prophylaxis as well as prevent relapses of GPA. So it has a dual function here. Relapses are common in about 30 to 50% of patients. And where we see relapses are particularly in patients who go off to college. They get distracted, they have their friends, they have their classes, their stressors, they forget to take their medicines. I actually have a couple of patients right now that I inherited from the pediatric rheumatologist. I'm an adult rheumatologist, and they have been in flares for a few months, and then they came to me because they forgot to take their medicine. So it's very important that you stress to these patients at medical adherence to therapy. So polyarteritis nodosa, PAN, these are medium-sized artery vasculitis. It can cause aneurysms and stenosis. The aneurysm and stenosis, and the reason why patients can have renal involvement is not because of a glomerulonephritis, but because of the aneurysm and stenosis of the renal artery. Males are more afflicted than females in a 2-to-1 ratio. The mean age of diagnosis is 9 years old. PAN is commonly associated with hepatitis B virus infection. And when you treat the hepatitis B, the arteritis goes away. Other infections have been linked to this condition as well, such as hepatitis C, CMV, parvo B19, and strep. But in addition to that, other rheumatic diseases can also cause PAN, such as Sjogren's, spondyloarthritis, and JIA. The symptoms for PAN include fever, orchitis. Orchitis may be the hallmark of this disease, just like in HSP. Patients can also have a mononeuritis multiplex. This is where they present with just foot drop. Rashes, erythema nodosa can also occur, as well as cutaneous ulcers. Now, the one thing about PAN is that the ANCA is negative. All right, there's no granulomas, and the ANCA is negative. In addition, there is no lung involvement. So this is very particular to PAN. Associated with Hep B, ANCA is negative, no lung involvement. Polyarteritis nodosa, the 1990 American College of Rheumatology criteria indicates that you can make or classify these patients of having PAN if they have weight loss, skin lesions, orchitis, mononeuritis multiplex, hypertension, evidence of hepatitis B, and the biopsy or angiographic findings of aneurysms and stenosis. So in terms of the third types of vasculitis here, it's microscopic polyangiitis. It's very similar to GPA, but there is no granulomas, all right? So we have GPA, PAN, and MPA, a lot of initials. This can cause a true pulmonary renal syndrome. Patients can have pulmonary hemorrhage, and they can also have glomerulonephritis. So it's very similar to GPA. The upper respiratory tract is not involved. So you're not going to see epistasis. You're not going to see the saddle nose deformity or tracheal stenosis. The P-ANCA is typically positive in patients with MPA. Remember, with GPA, granulomatosis, with polyangiitis, they have C-ANCA. MPA, P right here, have P-ANCA. Okay, that's the association. And the P-ANCA is pretty nonspecific. It targets myeloperoxidase, elastase, cathepsin G, as well as lactoferrin. You can also see P-ANCA in patients with inflammatory bowel disease. So let's look at this case. 12-year-old male was brought to the emergency department for evaluation of fever, dyspnea, hemoptysis, and gross hematuria. Mom noted for 3 months he has had fatigue, mouth ulcers, and occasional epistasis, but continued on his usual activities. 1 week prior to admission, he developed a cough and fever of 101 degrees Fahrenheit. Mom brought her son to an urgent care where he was given amoxicillin, but he failed to improve. On the day of admission, he coughed up about 2 teaspoons of blood and was short of breath. He noted blood in his urine, but he didn't have any joint symptoms, rashes, or photosensitive rash. On exam, his temperature is 101 degrees Fahrenheit. He has high blood pressure of 140/99, tachycardia at 112, and his O2 sats was 87% in room air. On exam, he appears chronically ill. HENT exam shows oral and nasal ulcerations with blood in the right nostril. He also has right maxillary sinus tenderness. His pulmonary exam shows crackles at the bases. Breathing is labored. And in terms of his abdominal exam, mild diffuse tenderness, no rebound, no garden. GU exam is unremarkable. He does have a few bruises on his shins, and his lab shows a white blood cell count of 11.5, an anemia with a hemoglobin of 10.2, platelets that are elevated at 490, mildly elevated LFTs, AST of 46, ALT of 54, SED rates 110, CRP is high at 12 milligrams per deciliter. It's important to look at the units. If this says 12 milligrams per liter, move the decimal over by 1, okay? But 12 milligrams per deciliter is pretty high. Urinalysis shows 3 plus protein, 3 plus blood, ANA is negative, C-ANCA is positive, P-ANCA is positive, anti-GBM antibody is negative. Which of the following is most likely in this patient? The patient has hepatitis B infection associated with the disease. Spirometry will show a restrictive pattern. Renal biopsy will show a pauciimmune necrotizing glomerulonephritis. P-ANCA targeting MPO specific for this disease, or granulomas are rarely found in this disease. Your answer, please. The answer is C. Well, I didn't tell you that this is a pauciimmune glomerulonephritis. We really don't see immune complexes deposit into the glomeruli. We see granulomas. But all these other answers, and when you approach a board question, you're not quite sure, do methods of exclusion. So Hep B infection is more likely seen in PAN. Spirometry will show a restrictive pattern. So sometimes spirometry will be normal, but it typically will show more of a tracheal stenosis kind of pattern rather than restrictive. Renal biopsy, this is the correct answer. P-ANCA targeting MPO is specific for his disease. This is actually in MPA, microscopic polyangiitis, and granulomas actually are commonly found in this disease. All right, so I just want to compare the small and medium vessel vasculitides. PAN, GPA, and MPA just kind of emphasize this. Don't feel bad if you got the last question wrong, because actually a lot of rheumatologists could get the last question wrong as well. So with PAN, remember it's medium-sized vessels. With GPA and MPA, they're smaller vessels. ANCA is negative in PAN, whereas you see C-ANCA with GPA, P-ANCA with MPA, although GPA patients can also have P-ANCA and MPA patients can have C-ANCA. But the association on board questions, they're going to definitely tell you C-ANCA and GPA. Pulmonary disease is common in GPA and MPA, but with MPA, you don't have the upper respiratory tract, so no nasal deformities, epistasis, or sinusitis. Glomerulonephritis is not seen in PAN, but it's seen in GPA and MPA. This is a pauciimmune glomerulonephritis. The association with hepatitis B is with PAN. GPA, you see sinusitis, tracheal stenosis, granulomas. Granulomas in the lungs and kidneys, whereas MPA, there's no granulomas. All right. So I talked about pulmonary renal syndromes with GPA as well as MPA. There's other conditions that can also cause pulmonary renal syndrome, such as lupus, Goodpasture's, and IgA-associated vasculitis. So know which diseases are associated with pulmonary renal syndromes, okay? Next, we have the large blood vessel vasculitis, Takayasu. It's also called pulseless disease. And the reason why it's called pulseless disease is when there's active inflammation, the blood vessel can stenose, and then you won't feel the pulse. It's the third most common childhood vasculitis after HSP and Kawasaki's disease. Symptoms can include fever, arthritis, myalgias, and fatigue. And these patients can have complications of stenosis in the large vessels. So it's very important when you get vitals to do a 4-extremity blood pressure check, because sometimes these patients can have malignant hypertension that goes undetected if you check a blood pressure in a vessel that's been stenosed. Ischemic findings are infrequent in children. It's when these children grow up to be adults. The proposed diagnostic criteria for Takayasu's arteritis in children is that there's angiographic abnormalities, either documented by angiogram or CT or MRA, and at least one of the following. If they have decreased peripheral pulses, claudication of the extremities, blood pressure difference of greater than 10 millimeters per mercury between the arms, audible bruits over the aorta or major branches, as well as hypertension. And these patients will be sick. They have fever. They have weight loss. They just don't look good. There's 2 phases for Takayasu's arteritis. The first phase is the inflammatory phase. This is the pre-pulselessness phase. So again, these patients have fever, fatigue, weight loss, elevated inflammatory markers. The non-inflammatory phase, so this is after the disease has burnt out, is called the occlusive phase. So these patients may present with limb claudication. They walk for a little bit, their legs hurt, they get tired. They can have dizziness, headaches, vision issues, and their inflammation markers are completely normal. How do you treat active inflammation? With the usual suspects, corticosteroids. We also use cyclophosphamide. We want to be very aggressive in this disease. In the event that they do have stenosis, we'll use antiplatelets and also anticoagulation. Now, there are possible roles of IL-6 inhibitors, tocilizumab. It's FDA approved for patients with giant cell arteritis, which is the older version, adult version of this. Behçet's disease. So Behçet's is also considered a vasculitis, and it's a vasculitis of the arteries and the veins, and it's the only vasculitis that will do this. If you do a biopsy of a lesion, you'll see neutrophilic infiltrates in arterioles as well as venules. And these patients will have the classic triad of oral ulcers, genital ulcers, and inflammatory eye disease. Again, the rheumatologic triad: painful oral ulcers, genital ulcers, and inflammatory eye disease. Inflammatory eye disease can be uveitis, a retinal vasculitis, or papilledema. Sometimes it could be painless, so it's important in somebody that you suspect to have Behçet's to go ahead and send the child to a pediatric ophthalmologist. The ulcers itself are very, very painful, and they usually occur in crops, and they take a long time to go away. Children will get oral ulcers, but usually they'll last at maximum about 7 days, typically 3 to 4 days. But patients with Behçet's will have ulcers that will last for weeks. In younger children, these patients can present with periodic fever, kind of like in patients with systemic onset JIA. So what's interesting is if you do microarray analyses of patients with Behçet's, they have very high levels of IL-1, so they're considered an autoinflammatory disease. Skin lesions are common. You can see erythema nodosum, so this is painful nodules. Patients can also have a necrotic folliculitis. Pathology test would be positive. This is where if you poke or prick the skin, about 48 hours later, you'll see a pustule. So patients who have their blood drawn or an accident or something, you can see a pustule 48 hours afterwards. These patients can also have GI involvement, so they'll have ulcerations in their colon or their small intestines, and it mimics inflammatory bowel disease. Sometimes it's indistinguishable from inflammatory bowel disease. Biopsy the lesions, and then you'll find a neutrophilic infiltrate in the vessels. The treatment of choice, steroids, colchicine, disease-modifying anti-rheumatic drugs as azathioprine or methotrexate, infliximab for colitis. So you treat it like you would inflammatory bowel disease. The next type of vasculitis is childhood primary angiitis of the CNS. Sounds scary. Vasculitis of the brain. It can cause childhood strokes. And you can see here on MRI evidence of a stroke in a child. And if you do an angiogram, you'll see stenosis right here. There's a little collateral that's starting to form, but there's a huge stenotic lesion here. There's two types of childhood primary angiitis of the CNS. Small vessel, and then there's the second type, medium to large vessels. In patients who have small vessel primary angiitis, imaging will be normal, and the way you confirm the diagnosis is by a brain biopsy. These patients will have generalized neurologic symptoms, nothing focal. So they can present with seizures, they can present with confusion or psychiatric illnesses, depression, anxiety, or psychosis. On labs, you'll see elevated SED rate, CRP. You can also see elevated platelets, anemia, chronic disease. And then if you do a lumbar puncture, they'll have elevated opening pressure as well as pleocytosis and high white blood cell count. Prognosis is generally good, particularly in patients with small vessel primary angiitis of the CNS. Now, if you look at the medium large vessel disease, they will have abnormal MRA as well as angiograms, and these patients can present just like looking like a stroke victim. So weakness in one arm. They can also have chorea, abnormal movements. They can present with headaches. But what's interesting is that even though they have all these deficits, their SED rate and CRP will be completely normal. All right, now we're leaving vasculitis and entering into the realm of lupus. Lupus is actually one of my favorite topics because I do research in lupus. About 20% of lupus is actually diagnosed in children under the age of 18. It's rare before the age of 5, and the incidence actually increases around puberty. It's related to the estrogen and the hormonal changes that these girls go through. If the child is African American, Asian, or Hispanic, these children typically have the worst prognosis. They have more end organ damage. Girls are more affected than boys in a 4-to-1 ratio, and that incidence goes up to 9-to-1 when they reach adulthood. Now, pediatric lupus is not the same as neonatal lupus. Neonatal lupus is where the mother of the child passes on autoantibodies to the infant, okay? And I'll go into detail about that later. So you're probably familiar with the 1997 American College of Rheumatology classification criteria for lupus, and you probably have the mnemonic SOAP Brain MD. So, and you have to have 4 out of 11 criteria. Every medical student memorizes this. S stands for serositis. It could be pleuritis or pericarditis. O stands for oral ulcers, but nasal ulcers can also occur. Typically, the ulcers are painful, but they can also be painless. So in a child that you suspect with lupus, always do a thorough examination of their nasal mucosa as well as oral mucosa. A stands for arthritis. This is not arthralgia. This is actually an inflammatory arthritis. P stands for photosensitivity. These children, they're very sun sensitive. They will burn easily and they feel worse whenever they burn. So sun protection is important. And in fact, it's very important that you tell the parents that a small sunburn can actually trigger a whole cascade of immune derangement. Like I have this one teenager, he has lupus. Male lupus is bad. Anyways, he was non-compliant with his therapy, non-compliant with his sunscreen and sun protection. He went to Cancun, came back with a massive sunburn, and ended up with renal failure and in the ICU. That's how severe the sun can affect the child. So sun protection is very important. And if it's a teenager, tell them they cannot smoke because tobacco actually can aggravate the disease as well. B from the SOAP Brain MD stands for blood disorder. It's a hemolytic anemia. So this is an immune-mediated hemolytic anemia. Leukopenia can occur, lymphopenia, as well as ITP can also occur in this disease. R stands for renal disorder. A stands for a positive ANA. It's very rare to see an ANA negative lupus patient. I stands for immunologic disorders such as antiphospholipid antibodies, double-strand DNA, Smith, RMP, false positives, syphilis test. N stands for neurologic disorder, and then the MD stands for the rashes, malar lesions, as well as discoid lesions. So when children present with lupus, fever, weight loss, tachycardia, and fatigue are the most common symptoms. And what's interesting is you can actually follow flares by their heart rate. So a child you suspect who has a flare typically will have tachycardia. Patients who have normal heart rates are probably not in a flare. They may have something else that's going on. And as a rheumatologist, everything that we see will be blamed on lupus. I mean, even if they stub their toe, their primary care doctor will send us patients like, this is lupus. So, inflammatory arthritis can occur in about 80 to 90% of patients. Typically, it's polyarticular, usually in the small joints like their hands, but also it can occur in the knees and ankles. X-rays are normal, so unlike juvenile idiopathic arthritis, we do not see a deforming arthritis that causes erosions. The deformities that you might see, typically in African American patients, is what we call Jacquard's deformity. They look like they have swan neck and boutonniere's deformities, but you can actually straighten out their finger and it looks perfectly fine. So we do not see on X-rays erosions, juxtaarticular osteopenia, just like we would see in patients with JIA. Skin lesions can occur in 70 to 80% of patients. Malar rash, discoid lesions, these are chronic cutaneous lesions, can cause scarring, follicular plugging. Photosensitivity can occur in these patients, and this is actually a reduplication of terms because malar rashes and discoid lesions are actually photosensitive. Patients will present also with alopecia, and it's a diffuse alopecia unless there's a discoid lesion that causes clumps of hair to fall out. About 50 to 60% of patients will have a glomerulonephritis. The International Society of Nephrology, Renal Pathology Society, labeled different categories of nephritis from 1 through 6. And essentially the ones that we treat are ISN-RPS, or formerly known as WHO class 3, 4, and 5. So that's where lupus can affect the kidneys and cause permanent damage. CNS disease can occur in 10 to 30% of patients. So these patients can present with seizures, they can present with headaches that's refractory to narcotics. Chorea, so these patients can have abnormal limb movements, and in fact, lupus is the most common cause of chorea in the United States. Cranial nerves are more affected than peripheral nerves, and psychiatric disease, such as psychosis, can occur in 10 to 20% of patients. For the hematologic manifestations, patients can present with a pancytopenia. Typically, this is an immunologically mediated cytopenia. The PT and PTT can be prolonged, and so if it is prolonged, think about the lupus anticoagulant. This is a misnomer because really these patients have a coagulable, hypercoagulable state, not a coagulopathy. And so these patients are at increased risk for DVT and pulmonary embolism. With regards to cardiac manifestations, they can have pericarditis as part of the serositis, but also Liebman-Sachs endocarditis. If you see Liebman-Sachs endocarditis, you hear a murmur, you get an echo, you need to check for antiphospholipid antibodies because these antibodies is what's causing the Liebman-Sachs. I'd mentioned before in terms of the ANA, it's typically always positive in children with lupus. If you suspect lupus and the patient is ANA negative, get a CH50, complement hemolytic system 50, CH50, to see whether or not this patient actually has lupus, because lupus is a complement depleting disease. The double-strand DNA is found in 60 to 70%. It's highly specific for lupus and portends a poor prognosis, renal involvement. Anti-Smith can be found in 33%, also associated specifically with lupus and poor prognosis. Complement levels, again, complement depleting disease, C3 and C4 and CH50 are low. And antiphospholipid antibodies, if the patient has it, are associated with blood clots. Older in life, they may have miscarriages. But also ITP is related to antiphospholipid antibodies. So one thing about the 1997 criteria is that it's outdated. Yeah, now I tell you, you have to learn new criteria, right? There were two other criteria that were developed. There was the 2012 SLIC criteria, the Lupus International Collaboration Clinics, and then more recently, the American College of Rheumatology and the European League Against Rheumatism developed new criteria that will be published this year, if not early next year. They've already presented it at our annual meeting last year and also at EULAR this year. And so the reason why new criteria develop is because, well, this is back in the 1990s. They've never been validated. And there's reduplication of term. Like I said before, a malar rash or a discoid lesion, they're photosensitive rashes. So why should we have photosensitivity as a separate criteria? There's also other cutaneous manifestations of lupus, as well as neurological manifestation of lupus that have never been mentioned in the 97 criteria. And we also have new information about antiphospholipid antibodies, and we also now recognize that complements is part of the deranged immune system. And so when they went ahead and validated the SLIC 2012 criteria, they validated the ACR criteria. ACR criteria actually did pretty well, although the SLIC criteria had better sensitivity. But because of the poor specificity of the SLIC criteria, the ACR developed the 2018 criteria. So what exactly are in the new criteria, both in 2012 and 2018? So it recognizes that these patients can have other skin manifestations as part of acute cutaneous lupus. So they can have bullous lesions. So this looks like huge blisters. They can have toxic epidermal necrolysis. They look like burn victims. These patients can also have just a plain old maculopapular rash that's not necessarily in the malar region. And then they also have chronic cutaneous lesions. Some of them look like warts. These lesions are deeper. They can cause scarring. Patients can present with a paniculitis, lupus tumidus that looks like a really bad ant bite, like hives, deep, thick, and painful. Chilblain's lupus is where there's painful nodules along the edge of the fingernails. With regards to neurological symptoms, these patients can present with mononeuritis multiplex, just like vasculitis I'd mentioned in PAN. They can also have a transverse myelitis. These patients can have a paralysis, as well as acute confusional states. For immunologic criteria, I'd mentioned about the low complements, but direct Coombs test is also being recognized as part of the new criteria. Now, what about treatment for these children? There's only 4 FDA-approved drugs for lupus: aspirin, prednisone, hydroxychloroquine, and belimumab, which was approved back in 2010. And it's only approved in adults, not in children. But do we use other therapies? Absolutely, off-label. The FDA didn't approve mycophenolate. The FDA did not approve azathioprine or methotrexate, but we still use it in children. And the reason why the FDA didn't approve these drugs was because our clinical trial sucks. We use too much placebo in terms of a background therapy. Because lupus patients make us so nervous. I mean, it can cause organ dysfunction. These patients can die. So we want to give everybody steroids. We want to give everybody high doses of steroids. So we really don't see the difference between placebo and controlled study drug, right? And not only that, the disease manifestation is so polymorphous. There are some patients who have renal disease, other patients who have CNS disease, and still other who has arthritis in joints. So one drug that targets multiple different aspects is very difficult to find. And then the duration of therapy and follow-up is actually short. So that's why a lot of our drugs aren't necessarily FDA approved, but we still use it because we know with small data that they do work. So let's talk about some of these drugs. Hydroxychloroquine, typically we use for skin and joint flares. It's been shown to decrease mortality and the severity of flares for lupus patients. So unless there's a good reason for you to stop hydroxychloroquine, don't do it, because patients can actually have really bad flares. They actually did a study. They looked at a group of women, these are adult patients, who've been in remission or low disease activity state from their lupus. And they've been in this way for about 5 years. And then what they did was they randomized this group into half where they stopped the drug and half where they continued. And they followed them for the next couple of years. And they found out that the group that stopped actually had flares, and the flares lasted longer and they were worse. So don't stop hydroxychloroquine unless there's a reason to stop it. And particularly with the new American Academy of Ophthalmology guidelines, we use a lower dose now, so the risk for retinal toxicity is a lot lower than it had been before. After 5 years of continuous use, the risk for retinopathy is less than 1%. After 10 years of continuous use, it's less than 2%. So I always tell the parents, it's like, the risk for death is a lot higher than the risk for retinopathy. Retinopathy is what we worry about with hydroxychloroquine. Now, azathioprine, mycophenolate, typically we do use these medications in more severe diseases, such as renal manifestations or CNS disease. And then cyclophosphamide, I'd mentioned before, these are for life-threatening or organ-threatening illnesses. Corticosteroids are used mainly for flares. We don't like to use it long-term. We will pulse the patient with methylprednisolone, usually 30 milligrams per kilogram a day. Now, if a child has psychosis, you have to ask yourself, is it because of the disease or is it actually because of the steroids that we give them? So what about Rho and La antibodies? Let's say that mom actually has lupus or has Sjogren's and she gives birth. What is the risk for neonatal lupus in the infant that you will be taking care of? So the risk for cutaneous lesions is about 7 to 16%. But if mom already had a child with neonatal lupus, subsequent pregnancy, that risk goes up to about 23%. The risk for congenital heart block because of these maternal antibodies that cross the placenta in the third trimester. Congenital heart block, where third-degree heart block occurs, is about 1 to 2%, and the risk for recurrence is 10 times higher if mom already had a child with congenital heart block. If mom had a child with cutaneous lupus, neonatal lupus, the risk for congenital heart block is 12.8%. So if mom has a history of positive Rho or La antibodies, it's important to get a fetal echocardiogram in utero every 2 weeks starting at week 16. Because the cardiologist or the high-risk OB can actually detect premature atrial contractions, pericardial effusion that precedes AV block. What can you do about it? If you do detect this, we usually give high-dose dexamethasone. But a lot of times the children end up, after they're born, either they die within a day or two if it's not recognized, or else they have to have immediate pacemaker placement. I actually have a patient who has Sjogren's. She got pregnant and stopped all her therapy because she thought, I don't want to expose my child to any medicine during the pregnancy. Hydroxychloroquine actually is protective in pregnancy to prevent these transplacental transfer of antibodies. Her baby was born with third-degree heart block and had to have a pacemaker placed. The child is healthy. He's now 10 years old, but he's had to have the pacemaker replaced every few years. What about antiphospholipid antibodies and lupus anticoagulant in mom? What's interesting is that the mother who has antiphospholipid antibodies and lupus anticoagulant, they're at higher risk for pregnancy losses and also for preeclampsia and HELLP syndrome. So HELLP syndrome stands for hemolysis, elevated liver enzyme, and low platelets. And usually, let's say a teenager got pregnant and their antiphospholipid antibody is positive. So HELLP syndrome can occur earlier in the pregnancy. So instead of in the third trimester, it can occur in the second trimester. So it's something to recognize. Again, I had a patient who has antiphospholipid antibodies, a different patient. She decided to stop her hydroxychloroquine. And she looked terrible when she presented, probably in about her 11th week of pregnancy. I obtained labs, saw that her liver test was high, her platelets were low. I called her high-risk OB, and I said she's going to be in HELLP syndrome and really needs immediate medical attention. He's like, that's impossible. She's starting her second trimester. And I said, you got to see the patient. So when he saw the patient and did the sonogram, she had no amniotic fluid, her liver test was even higher, and the baby is dead. All right, so it's something to recognize. Hydroxychloroquine is important. 2 is antiphospholipid antibodies can present with HELLP syndrome earlier in pregnancy. Now, patients who have antiphospholipid antibodies, their child may have an increased learning disability. Okay, so you're taking care of the child, mom has antiphospholipid antibodies or even Rho antibodies. Dyslexia is also common in the child. I'm currently doing a registry called the Planned Registry, Pregnancy and Lactation Autoimmune Network, looking at the children of these patients and seeing what else is affected by the children if mom has these diseases. All right, so here's your question. How can you differentiate lupus from systemic JIA? A, fever is not common in systemic JIA. B, less than 5% of lupus is diagnosed in children under the age of 18. C, pericarditis is rare in lupus. D, SED rate is low in systemic onset JIA but high in lupus. E, X-rays in pediatric lupus are normal, unlike in systemic JIA where you see osteopenia and joint damage. Please enter your response. So the answer is E, correct. Fever is common in systemic onset JIA. About 20% of lupus is diagnosed in children. Pericarditis is not rare. SED rate in systemic onset JIA is elevated, whereas in lupus patients, it's not very reliable. So just like in patients with enthesitis-related arthritis, sometimes patients could be in remission, their SED rate is high, sometimes their SED rate is low, and their disease is very active. Next, I want to turn your attention to mixed connective tissue disease. This is exactly what it sounds like. It's just a mix of different things. Mixture of lupus, mixture of JIA, mixture of systemic sclerosis, or dermatomyositis. Girls are affected more so than boys, and the symptoms are Raynaud's, fever, arthritis. They can have hand edema, rash, myositis. It's just a melee of different things. Mortality is related to restrictive lung disease. So you have to see, so in GPA, remember their flow volume loop goes up, then it flattens out and it goes down. So in patients with mixed connective tissue disease, if they have a flow volume curve, it's a restricted pattern. So normal is bigger, restriction is smaller down. And they can also die related to infections from immunosuppression. But interestingly enough, these patients who have a positive RNP antibody, they actually do better than patients with lupus or systemic sclerosis. Sjogren's. So Sjogren's is actually rare in children. Boys are not affected as much as girls are. Again, many of our autoimmune diseases, girls are more commonly affected because of the hormonal state of estrogen. But the symptoms are dry eyes, dry mouth. They can have dry skin. If their gut is dry, they'll present with constipation, sometimes nausea. If their lungs are dry, they'll present with interstitial fibrosis, which is extremely rare. So Sjogren's is rare in children. ILD is even rarer in children. So rarely, even more rare than that, is transverse myelitis. I've seen only one case in my career where a patient with Sjogren's present with acute paralysis in their legs. Renal tubular acidosis can also occur. Usually it's a distal renal tubular acidosis, and it's rare in children as well. You'll see hyperkalemia. So the American College of Rheumatology and EULAR 2016 classification criteria for Sjogren's, basically you can classify a patient as having Sjogren's if they have 4 or more criteria. So the antibodies of Sjogren's, Rho or La. If you do a minor salivary gland biopsy, they can have a focal lymphocytic sialinitis focus score of greater than 1, abnormal ocular staining score, Schirmer's test. This is where they put litmus paper right under the eyelid and see how much further the tears will travel on the litmus paper, or unstimulated salivary flow of less than 0.1 milliliters per minute. So think about a child with Sjogren's if they present with recurrent keratitis, not just mumps, but keratitis here associated with dry eyes. Now, these patients can present with SCLE lesions, subacute cutaneous lupus lesions. It looks almost like ringworm, central clearing, hypererythematous borders, heaped up. but it's photosensitive, okay? Patients also can present with hypergammaglobulinemic purpura, and the differential diagnosis would be lupus, other autoimmune diseases, tuberculosis, which is a great mimicker, as well as infiltrative diseases. The main treatment of choice for Sjogren's patients is to avoid anything that can actually make their dry symptoms worse. So antihistamines, antidepressants, decongestants, diuretics. Now, if you have to use these agents, obviously use them. But it's very important that these children see their dentists and ophthalmologists regularly to see if there's any damages related to the Zika symptoms. So these patients can have recurrent cavities. And in fact, untreated, I have this young lady, she's now 25, all her teeth fell out because of severe periodontal disease related to Sjogren's. These patients can have corneal scratches as well. That's why it's important to see the ophthalmologist. We treat dry eyes with tear duct plugs, autologous serum drops. So this is where we take serum from the patient, spin it down, and dilute that serum layer, and then allow the patients to drop it into their eyes. Very effective. Pilocarpine, as well as cevimeline, are cholinergic agonists to stimulate saliva. Doesn't work very well for dry eyes. We use anti-malarial agents such as hydroxychloroquine for skin and joint issues. Now, the one thing about Sjogren's is that it can increase the risk for lymphoma. So if you see a patient who has Sjogren's and they have diffuse swollen lymph nodes that will not go away, think about lymphoma and get that lymph node biopsied. Juvenile dermatomyositis. Girls are more commonly affected. There's a bimodal distribution. It's very interesting. You can have it in younger years, 3 to 7 years old, or in the teenage years. Now, the rash is associated with proximal muscle weakness. It's not distal muscle, so the fingers are fine. It's the proximal muscles, like the shoulders, the hips. Patients will have difficulties climbing stairs. And there's classic rashes associated with it. This is a heliotrope rash, and I don't know if you know why it's called a heliotrope rash, but it's because of the heliotrope plant, sun-loving, right? So these patients have a photosensitive rash. They can also have it in their scalp, and it is so itchy. I don't think you'll read this anywhere, but the scalp is very, very itchy. They think they have lice. When you check, they don't, but their scalp is really red, and that's what annoys them more than anything. There's a seasonal clustering of juvenile dermatomyositis, so the question is, could there be an infectious agent that triggered the immune system? Gottron's papules are these flesh-like lesions on top of the knuckle. Okay? Now, lupus patients can have redness on their fingers, but it spares the knuckles. You see the difference in lupus versus Gottron's papules and dermatomyositis here? Patients can also present with dystrophic calcification, so they can have calcinosis cutis, and these can ulcerate and become very, very painful. I took care of a child, she was about maybe 5 years old, with juvenile dermatomyositis and a lot of cutaneous calcinosis. Her mom can't even hold her because it hurt so much. So now, if patients have skin ulcerations, it can portend a GI vasculitis, and that's a very poor prognosis. Patients can also have dysphagia, dysphonia. Sometimes they have difficulties breathing because their accessory muscles of the thorax is affected. Now, one thing about children with dermatomyositis, there's no increased risk for malignancy compared to adult patients. So the way you make the diagnosis of dermatomyositis, heliotropic rash or Gottron's papules, very specific for the disease, +2 for probable or 3 for definite diagnosis of these 4. Symmetrical proximal weakness, symmetrical, not asymmetrical, proximal muscle weakness. Now, these patients will have high CK and autolase. Do you remember when I mentioned in patients with systemic onset JIA, they'll have normal CK but high autolase? Well, these patients with dermatomyositis will have both, elevation. LDH is another measure for muscle. Transaminitis, so their LFTs will be elevated, but actually this is a reflection of their muscle disease. It's not true liver disease. If you do an EMG, you'll find that it's abnormal. And when you order an EMG nerve conduction study in these patients, order it only on one side. because if you have to biopsy the other side, you don't want it affected by the puncture wounds of the EMG, all right? But in children, a lot of times we'll just do an MRI instead of the EMG. Biopsy actually is the gold standard in order to see the abnormalities. The way you manage dermatomyositis is with high-dose steroids, IVIG, or sub-QIG. We use hydroxychloroquine for mild cases where they have rash and very minimal muscle weakness, but we also use other disease-modifying anti-rheumatic drugs. There may be a role of biologics. I don't know if you read in the last 2 or 3 years, there was a publication about rituximab and the role of pediatric dermatomyositis, and they also included adult patients, polymyositis and adult dermatomyositis. It failed to meet its primary endpoint, but the way the study was designed was that they looked at patients after 8 weeks of being given drug. There was a small placebo control phase of 8 weeks. Well, rituximab takes 3 months to kick in. So the trial failed because they looked at it at 8 weeks. But when they looked at these children over a period of a year, all of them met criteria for improvement as set forth from the study. So the trial design was poor. So rituximab still is a possibility for these patients. Sun avoidance to prevent the itchiness and the rash aggravation. And we recommend physical therapy for these patients. It used to be that we recommended bed rest. We didn't want to make the CK go even higher. But actually, patients got worse. So we really want them to strengthen the muscles that are unaffected. Systemic sclerosis, otherwise known as scleroderma. So this is where there's abnormal deposition of fibroblasts. And there's a lot of collagen being deposited, so it looks like they just have diffuse scarring everywhere. There's 2 forms, limited systemic sclerosis and diffuse systemic sclerosis. And the way you tell the differences between the two is where the sclerosis stops. If it stops at the elbow crease or at the knee, it's limited. If it's diffuse, which extends beyond the elbow crease and the knee, it's diffuse systemic sclerosis. Because both of them can actually have calcinosis, Raynaud's, esophageal dysmotility, sclerodactyly, as well as telangiectasia, what we call CREST syndrome. The one thing about diffuse systemic sclerosis, these patients tend to have more organ involvement. So they can have renal crisis, as well as pulmonary fibrosis. Patients with limited disease can have pulmonary hypertension, but we normally don't see a lot of fibrosis. So any organ can be affected. If it's affecting the GI tract, these patients can present with reflux, dysphagia, and usually what we do is we send them to get esophageal dilation evaluation from the GI specialist. If they have lung involvement, I'd mentioned pulmonary hypertension, ILD, but also these patients can present with alveolitis, and alveolitis portends a poor prognosis. This is where we want to be very aggressive and treat. Their kidneys can be affected. These patients can present with scleroderma renal crisis, typically associated with early onset of diffuse disease and use of high-dose steroids, so 20, 30, 40 milligrams of steroids, prednisone. The way you actually diagnose is not only just by clinical exam, but laboratory testing might show a positive ANA. SDL70 is associated with diffuse disease, whereas anticentromere is associated with limited disease. And if they have lung involvement, get a high-resolution CT scan. There's not a lot of therapies for systemic sclerosis. We tried DMARDs, but nothing seems to work unless they have alveolitis. So we treat whatever organ is affected. We like to use ACE inhibitors for patients with scleroderma renal crisis because that will decrease their risk for morbidity and mortality. Now, you'll encounter this, because I've encountered quite a few cases, actually even just the last few years. It seems to appear in crops of patients who come in. Morphia. Morphia is where they have a patch of sclerosis. And this is just all scar tissue. Now, if they have a linear line, this is also called en coupe de sabre, sometimes these lesions, morphia as well as linear scleroderma, can go deeper into the tissue, affecting the muscle, affecting the bone. If a child has a lesion on his face, then the child may actually have abnormal bone growth of his teeth and also seizures. We actually are aggressive in treating morphia cases, particularly if it involves the deeper structure. I'll use steroid injections, methotrexate, mycophenolate. For the skin lesions, phototherapy, UV phototherapy also works. So I'm going to give you this next question. Patients with diffuse systemic sclerosis and pulmonary involvement are more likely to have which flow volume curve on the spirometry? Is it A, B, C, or D? Your answer, please. C is correct. It's a restrictive pattern. So when you're asked a board question, they don't necessarily say, what is the diagnosis? They will say, well, interpret this test result. And they give you all the scenarios, and then they say, what do you do next? So the first one is actually a normal volume curve. This is what is anticipated. This is what is done by the patient, expected and actual. And so you can see here that this is what we would see for tracheal stenosis of patients with granulomatosis with polyangiitis, okay? So this is what I talked about going up, being flat and going down, tracheal stenosis. This is a restrictive pattern. You see that it's lower than what is expected. Expected is out here. It's lower down here. And this is an obstructive pattern. Usually we see this in patients with COPD or asthma. All right, next question, sarcoidosis. Sarcoidosis is a multi-system granulomatous disease. It can affect any organ ranging from the lungs, the eyes, the skin, CNS, and also lymphoid tissue. Patients can present with hyaluroadenopathy, erythema nodosum, uveitis, hepatosplenomegaly, arthritis, or just plain old fever. When you biopsy the skin lesions, you'll see non-caseating granulomas. Okay. Whereas in GPA, you'll see sometimes necrotic or caseating granulomas. In tuberculosis, you'll see caseating granulomas. Sarcoidosis is non-caseating. You manage these patients with steroids, disease-modifying drugs. They actually respond very well to monoclonal TNF inhibitors, such as adalimumab and infliximab. Blau syndrome is a familial sarcoidosis, and this is where there's the triad of uveitis, rash, and arthritis. And there's a mutation in NOD2 gene. It's an autosomal dominant condition. Lofgren syndrome is where they have lymphadenopathy, rash, and arthritis. Okay, so Blau syndrome is a familial, and this is its association. Now, joint hypermobility is actually a kind of like a favorite and fun thing for me because I have it. It's common in children. Typically, these patients are asymptomatic, and as they grow older, they tighten up. And girls are more commonly affected than boys. About 4 to 13% of children are affected by this. And how we measure joint hypermobility is if they have a Baton hypermobility score of 5 or more. Now, patients can present with joint symptoms. This is a non-inflammatory condition for joint pains. So in terms of the Baton hypermobility score, this is where they have passive dorsiflexion and hyperextension, the 5th NCP. You can see that I can do that. They can also have passive apposition of the thumb to the flexor aspect of the forearm. You can see I can touch my thumb, right? And I'm seeing some of you trying it too out in the audience. They have hyperextension of the elbow greater than 10 degrees, hyperextension of the knees, and active forward flexion of the trunk where they touch the palms of their hands to the floor. I can't do that anymore. I used to. And so these children, when they're younger, they're really good gymnasts, right? They can do crazy tricks. They'll do the splits this way. They'll put their legs around their neck. They'll dislocate their shoulders just to show their friends that they can do it. And so sometimes they can have injuries, though. And so that's where the Brighton score comes in. And this accounts for recurrent injuries like dislocation, tendinitis, bursitis, skin hyperelasticity. And so the association of joint hypermobility syndrome is that sometimes these patients have inherited diseases such as Marfan's or Ehlers-Danlos syndrome. But most hypermobility syndromes, they're benign and they're self-limiting. We recommend exercise, core strengthening exercise, and analgesics. We really don't intervene much. Sometimes we'll give anti-inflammatories, NSAIDs, to help with the joint symptoms. But most of the patients usually will grow out of it. All right, so I'm going to give you this question. 16-year-old male comes for evaluation of his joint symptoms. He notes his sister was recently diagnosed with Ehlers-Danlos syndrome and also postural orthostatic tachycardia, POTS. He reports fatigue and pain in his shoulder, knees, neck, and back. He's pretty tall. His blood pressure is a little bit low, and you hear a 2 out of 6 diastolic murmur. This is his exam. So look at his chest. This is pectus excavatum. His arm span measures 86 inches, but he's only 75 inches in height. And he can bring his thumb over his second MCP joint, which I can't do. So which of the following is the appropriate next step? Do you order physical therapy for this patient? Do you refer him to a geneticist to rule out Ehlers-Danlos syndrome? Do you order an EKG? Or do you order an echocardiogram or prescribe NSAIDs for his joint pain? Best answer. Great. You would order an echocardiogram because you heard that 2 out of 6 diastolic murmur, because this patient probably has Marfan's. Yes, you can order physical therapy for him, but that's not going to change his life. Ordering an echo and detecting aortic insufficiency may change his life because it could be repaired, and he's at risk for sudden death. Referring to a geneticist to rule out or confirm EDS because his sister has it, that's not going to, again, be the appropriate answer. An EKG won't tell you much about the murmur. Sometimes, if it's really severe, then yes, there may be abnormalities in EKG. And then NSAID, he probably, have already tried some NSAIDs for his joint pains, but this is the correct answer. So there's other pain syndromes in children. Fibromyalgia is a hypersensitivity syndrome. It's a pain amplification syndrome. And some children will have hypersensitivities to other senses as well. So lights may be brighter, noises may be louder, pain is magnified. So the new diagnostic criteria for adults was developed in 2010. It has not been validated in pediatric patients. Typically, these children have had some kind of trauma, whether it's related to physical trauma, emotional trauma, or they've suffered from a chronic illness, something that stresses them out. There's actually a learned behavior about this. If mom has fibromyalgia, then child will develop this pain amplification syndrome. That's why in my adult patients that I diagnose with fibromyalgia, I always tell them, if you have a child, you cannot act this way, where you're like so tired, fatigued, I have a headache, I don't want to do anything. You can't just moan all the time, because the child's going to pick up on that. And who's the child's hero? Mom, right? Mom is their hero, dad is their hero, and they're going to do exactly what mom and dad does. So I tell my patients, you know what, you may not feel like playing with them right now, you may hurt, I understand that. Go into the room, take a break, lie down, tell the kid, I'm going to go into the bathroom real quick and I'll be right out, and then just smile and act like everything is good, okay? So this is a learned behavior in children, but in children it's very hard to treat. You have to send them to cognitive behavioral therapy, physical therapy, perhaps even to psychiatry. So this is one of those things that if we can intervene both in mother, then the child will actually improve. Typically, there is no evidence of joint swelling. The labs are all normal. These are the tender points of fibromyalgia in adults, but also you can find them in children. The new criteria says you only need to have 3 areas of the body. So if you put a line down the spine and across the hips, any pain in 3 quadrants actually suffices for the diagnosis. These patients will have poor sleep. They feel tired all the time. They may have cognitive, what is perceived cognitive dysfunction. They just can't remember much. Like I, left my homework somewhere, I don't know where, or I forgot to do something. And what's interesting is that these patients who have fibromyalgia or pain amplification syndromes, they tend to miss school much more than patients with juvenile idiopathic arthritis, okay, or lupus. They always say they have stiffness, and the stiffness is there all day. Now, there's a couple of reversible forms of fibromyalgia. One is actually osteomalacia, so low vitamin D, rickets. These patients have severe diffuse body pain, so check a vitamin D level. And if you supplement it in a patient with very low levels, their joint symptoms actually get better. These patients may have thyroid dysfunction, so check a thyroid level. If it's abnormal, supplement it, and their symptoms may improve. We do not use narcotics to treat these patients. Psychosocial intervention, we want to improve their sleep. Sometimes we'll use amitriptyline, cyclobenzaprine for nighttime sleep disturbance, but a lot of times we just want them to try to not rely on medication. So the cognitive behavioral therapy, biofeedback, physical therapy, actually is the mainstay of therapy for children. All right, 14-year-old female was brought in by her mother for complaints of diffuse arthralgias, myalgias, fatigue, and headaches for last year. She has no history of camping or being out in the city. She denies rashes, photosensitivity, or alopecia. On exam, vitals are normal. Exam was unremarkable except for 18 out of 18 tender points. Her mother insists her daughter be tested for lupus and Lyme disease because she knew people who were disabled from these diseases. Now, all these case scenarios that I give you, they're actually real patients of mine. Okay? So what would you do next? Would you check an ANA? Would you check Lyme serology just so that mom will be happy and leave you alone? Do you reassure the mother that her daughter does not have Lyme and lupus and prescribe exercise and cognitive behavioral therapy? Do you go ahead and just treat her for Lyme disease with doxycycline? Or do you go ahead and prescribe prednisone 20 milligrams per day because this patient has lupus? Perfect. And I am so glad you got this answer right because, like in my practice, I don't treat fibromyalgia and pain amplification syndromes anymore, so it's all you. Amyloidosis. All right. So we're in the home stretch here. Amyloidosis is the extracellular accumulation of protein fibrils that interferes with organ function. And the classic buzzword is apple green birefringence under Congo red dye, light stains, and polarized lights. Okay, so apple green birefringence with Congo red dye under polarized light. Now, amyloidosis has been associated with chronic inflammation. So that chronic inflammation can be from lupus, from JIA, inflammatory bowel disease. It can affect the kidneys, the heart, the liver, the bone marrow, GI tract, or the CNS. The way you diagnose it is you got to get tissue. So the abdominal fat pad is probably the least invasive. Some people do rectal biopsies or biopsies of the tongue, and the treatment is actually managing the underlying cause. The autoinflammatory diseases, these are totally different from autoimmune diseases because autoinflammatory is where there's a lot of inflammation and not necessarily a lot of antibodies, okay? So these are periodic febrile syndromes. Fever can occur and occur with certain degrees of frequency. Typically, a child will have fever at least 3 episodes in 6 months, and the pattern is different among the different disorders. There are certain genetic abnormalities associated with these diseases, and you got to exclude infection and malignancy. These are the types of autoinflammatory diseases, and I'll go into detail for a few of them. The most common one that you're going to encounter is PAFA syndrome. It stands for periodic fever, aphthous stomatitis, pharyngitis, and cervical adenitis. So again, it's exactly what the name says. These patients will have fever, mouth ulcers, sore throat, and lymphadenopathy. Prognosis is really good. There's no amyloid deposition here. The fever lasts typically about a week and occurs once a month. Typically, these children are young. Mean age is about 3 years old. And the way you treat these patients, you go ahead and give them prednisone, 1 milligram per kilogram a day, twice a day, for 3 doses. And typically the fever stops in their teenage years. There's a possible link of an infectious agent with this because some children respond to tonsillectomy. There's also a response to cimetidine as well as colchicine, and there's no recognizable Mendelian inheritance pattern with PAFA syndrome. Then you have familial Mediterranean fever, FMF. This is associated with an MEFV gene that codes for pyrin, and pyrin regulates neutrophil inflammatory responses. Typically, the fever cycle is a lot shorter than FAFA syndrome, so typically about 3 to 5 days, once a month. Usually the children presents before 10 years of age. They can have severe abdominal pain with a fever. They can have scrotal swelling, pleuritis, pericarditis. I mean, these patients are sick. When you check their labs, their saturate CRP will be high, the white blood cell count will be high with flares, and they'll respond to colchicine. Really dramatic response, milligrams twice a day, or IL-1 inhibitors. The complication here is that these patients will develop amyloidosis. If not treated, they can die in their 20s and 30s. The next one is TRAPP syndrome, also known as Hibernian fever. So think about TRAPP as being trapped in a fever. So these fever cycles are about 2 weeks. So FAFA is about 1 week, FMF is about 3 to 5 days, and TRAPPS, the fever cycle is about 2 weeks. The gene defect here is TNF-RSF1A, and it codes for the receptor for TNF. So they can have severe abdominal pain, just like patients with FMF. They can have conjunctivitis, periorbital edema. They will not respond to colchicine. So the treatment of choice here is IL-1 inhibition, other biologics, and NSAID steroids. These patients will also develop amyloidosis. Hyper-IgD syndrome. Of all the autoinflammatory diseases, this is also one of the more common ones. It's an autosomal recessive found in the Dutch and French ancestries. So the gene associated with IgD, hyper-IgD syndrome, is mevalonate kinase, MVK gene, and this causes a high level of IL-1. Typically, these patients are very young. They're under 1 year old. Fever here lasts for about a week, every 1 to 2 months. These patients can have abdominal pain, non-migratory erythematous rash, ulcers, splenomegaly. And if you check their IgD levels, it's high. IgA can also be high. Amyloidosis is rare. And so there's a panel, if you order on your labs, there's a panel for autoinflammatory disease genes. And you can order it as a full panel, and it'll come back whether or not patients have MEFV, if they have the TNF-SFR gene, or hyper-IgD MVK gene. So it's pretty nice because the lab panel will do all that for you because they present very similarly with regards to fever patterns and presentation. All right, this is your last audience response question. 8-year-old Middle Eastern boy brought in by his parents for evaluation of fever. It occurs once a month, lasts for about 3 days. During the episodes, he has severe abdominal pain. He also has chest pain, joint pains, and rash when his fever is present. Between episodes, he's perfectly fine, kind of like systemic onset JIA. His uncle also had this as a child and died of an enlarged heart and renal failure at age 35. Which of the following tests would you order to confirm this boy's diagnosis? Would you order an ANA, a rheumatoid factor, CRP, MEFV gene, or TNF-RSF1A? D, MEFV gene. This patient has familial Mediterranean fever. The patient doesn't have lupus, so it's not an ANA, nor rheumatoid arthritis. CRP will be elevated. It's very nonspecific. TRAPS is when the fever lasts for 2 weeks. So in your handout, you'll have high-yield pearls that just went over all the highlights of everything I talked about today. So I really appreciate your attention, and I'll be available for questions.